Morning, Nueva.
Good morning po, Doc.
Oo. Pwede bang pakisend na lang sa Viber natin yung iyong
Ay, sige po, Doc.
protocol? Oo, para hindi na mag-open ng
Saglit lang
email.
po, Doc, ha. Good morning po, Doc. Already sent to your Viber po, Doc, the protocol po.
Thank you.
Okay po, Doc. So, good morning, everyone. Today, we'll be having a mortality conference. This is a case which was handled by the following residents on the following dates. So, we will be taking turns in presenting the course in the wards for the patient, depending on the time that we have handled this patient. So, the objectives of this presentation is to present a case of an 18-year-old female who developed septic shock secondary to healthcare-associated pneumonia with hypoxia, dilated cardiomyopathy, chronic malnutrition, stunted, severely wasted, secondary to avoidant restrictive food intake disorder, COVID. And second objective would be to improve overall patient care for patients presenting with above psychiatric diagnosis. So this is the case of CP, an 18-year-old female, single, grade 12 student, a Roman Catholic from Indaguman, Davao City. So she was referred by the Pedia department for evaluation and co-management of the impression of the eruption nervosa, and the chief complaint of the patient was dili ko kakao. The sources of information for this presentation was the patient, the elder sister, the niece, the cousin of the patient, the RIC, and the ward nurses. So for the pre-morbid personnel, CP was described as competitive and always wanted to be on top of her class. She is a consistent honor student, a top student in her class. And she is particular that her table should always be neat, does not want others to touch her things. She argues with her sisters if her things are rearranged. According to the niece, there was no day where the sisters did not argue with each other. According to the sister, CP was often critical and would report their actions to their mother, and thus the sisters would be reprimanded. CP was close to her mother and tries to please her by attempts to please her mother by being an achiever in school. She is described to be a perfectionist and would make multiple attempts to perfect her schoolwork to achieve a higher grade. She is not comfortable when she is not top of their class, and she is competitive towards her other classmates. CP has strained relationships with her sisters, and she has also few friends in school. CP is very studious since she was in her elementary years and would prefer to study rather than go out with her friends, with their sisters and friends. And she also prefers to stay at home. She is very specific with food since she was a child. She was a picky eater and would only eat specific brands of food. She only buys specific food in specific stores or restaurants and will not eat or touch food if the brand is not okay. Like, for example, she will not eat hot dog unless the brand is tender juicy, or the size should always be regular and not otherwise. So for those who are present with her, 3 months prior to admission, the patient, together with her classmate, the top 2 and 3 of their class, together with their mothers, went to the class advisor's house to submit the project. On their way home, they stopped by a street food stall, and the mother of the top 2 students bought banana turon, which distributed to all of them. Allegedly, CP choked on the banana, which was spontaneously released. The following day, however, CP experienced abdominal discomfort and loose bowel movement, which resolved spontaneously without taking any medications. CP believed that just her daughter was her competitor. CP's mother brought her to the faith healer who told them that they were really cursed. Both CP and her mother believed and complied with the prescribed prayers by the faith healer. CP denied intake of any unknown substances from the faith healer, although she was given liniments to be applied on her abdomen. She became preoccupied that eating certain foods can make her vomit and thus limited her intake. And although she would try to eat minimal food, she would often vomit because she would feel that it was not right. Lain lang sa paminaw. In the interim, CP was noted to have loss of appetite, which eventually progressed to refusal to eat food. She later claimed of having a bad taste or discomfort on the throat, or that the food smells bad. However, her reasons for not eating was not consistent as they would vary. She only eats a little and was noted to vomit after taking food, especially when forced by family. She would cry when forced, and when reprimanded, she would eat but vomit afterwards. She started to have progressive weight loss and was noted to have prominent cheekbones due to the weight loss. 1 month prior to admission, the eldest sister was worried of the patient's condition. Hence, consult at a private psychiatric facility was done. However, the diagnosis was not disclosed. According to the eldest sister, the mother forbade the bringing of the patient to the hospital because she believed CP's condition was due to the curse. And later on, the mother blamed the eldest sister of CP's condition. However, the sister persisted and defied her mother and brought CP to a private hospital. She was given unequal medications and was advised admission for medical management and was subsequently transferred to SPMC for further management. So this patient was referred on hospital day 2. For the past psychiatric.
Sorry.
Yes, but
What was the management there?
For the sa private hospital po doc, they did not disclose the diagnosis and the medications were unrecalled po doc.
Okay.
But she was ano po doc, she only stayed there for a day or two and was transferred to SPMC for further management. For the past psychiatric and past medical history of this patient, it is unremarkable, as well as the family history. CP was considered as her mother's favorite, which caused the eldest 2 daughters to be jealous of CP and caused a rift between the 2 elder sisters and CP. The eldest sisters would often gang up on CP and would often bully her by calling her chokoy chokoy, which is a term they used to call a dog. And because they saw CP as a dog who would always follow their mother. The strain between the mother and the eldest daughter caused the eldest daughter to run away at 14 years old. The second to the eldest, on the other hand, was left, and she received their mother's anger and was often compared to CP. The eldest sister and the second to the eldest had still constant communication, and the eldest would often give money to her sisters, except to CP. The youngest sibling is currently 8 years old and is the baby of the family with good relationship with the other family members. So the father is a 60-year-old male high school graduate, retired army, while the mother is 51 years old, housewife. The eldest is 26 years old. and the second eldest is 20. CP is 18 years old, and they have a fourth sister, which is who is 8 years old. So during the course of the patient's admission, the main support system was the eldest and the second eldest. So for the anamnesis, CP is third among four siblings and born to a GP 3003 35-year-old mother. Although she was unplanned, but she was wanted. There was no known complications during pregnancy and delivery, and no known medical illnesses. CP was not breastfed, according to her sister. CP was immediately bottle fed after she was born, and complementary feeding was given at around 7 months. There was no reported problems in taking care of CP, and she was described as being similar to other children her age. Although it was not formal, she was toilet trained at around 3 to 4 years old, wherein she must relieve in a makeshift potty and would be verbally reprimanded and pinched whenever she soils her undergarments. By the age of 4 years old, she was able to go to the comfort room alone, but still needed assistance when cleaning up. She did not have any instances of thumb sucking, temper tantrums, head bumping, and other contact problems. She grew up shy and slow to warm up as a child. CP began going to school at 5 years old, and she only had few close friends and preferred to keep it that way. At a young age, CP's mother would nag at her about performing her best at school. CP was very serious about her studies and was described as a perfectionist, which caused her classmates to bully her, such as teacher's pet or not deserving to be first honor or sip, and would lead to them bickering about it. Her mother continued to pressure her at school, and she started to sleep very late just to be able to study. She slept at 1 to 2 a.m. When she wakes up in the morning, uh, she would skip breakfast and went directly to answer her modules and homeworks. She heard that a comment that she is not deserving to be a valedictorian, hence she felt more pressured and pushed herself harder on her studies. The family belongs to the Roman Catholic faith. Although they believe in God, they are not churchgoers. And moreover, CP and her mother were described as superstitious. So this patient is a G0 with menarche started at 12 years old, with regular menses lasting 3 to 5 days with moderate flow, 2 to 3 pads per day. However, starting 2 months prior to admission, there were no menses noted already. She identified herself as female and attracted to the opposite sex and had a male crush in school. She is not sexually active. For the substance use, she denied use of caffeine, alcohol, cigarettes, and illicit drug use. So, Dr. Shah.
Hello, good morning, everyone. To continue with the physical examination, the physical examination was done by the RIC, as I was not able to come near to the patient because during this time she was on the surveillance ward, awaiting for the swab result. So for the physical examination, the patient was conscious during that time, the day of evaluation. She was coherent and not in respiratory distress. The patient appeared weak and poorly nourished with the following vital signs: heart rate of 130 beats per minute, RR of 22 cycles per minute, temperature of 37.3, blood pressure of 90 over 60, with oxygen saturation of 96 at room air, with weight of 29 kilograms, height of 150 centimeters, with BMI of 12.8 kilograms per meter squared. The patient's skin was dry, warm, with perturgor and mobility, and with hypopigmented epidermal desquamation. She had a nectaric sclerae with and oral mucosa. Was no lymphadenopathies. She had chest expansion with decreased breath sounds at the right lower quadrant. Um, She had a dynamic precordium with distinct heart sounds and no murmurs were present. For the abdomen, she had the extremities emaciated with for the neurologic examination, PCS 15, no meningeal signs with intact cranial nerves.
May I know where is the hypopigmented epidermal desquamation located?
Sorry, yes po, Doc.
Kasi yung skin hypopigmented epidermal desquamation, where is it located? Is it generalized all over the body? Or where is it specifically located?
On the upper and the lower extremities po, Doc. However, I was not really able to see kasi I was not able to come near to the patient po, Doc.
How did you examine that?
The physical examination was done by the resident in charge po, Doc. As this patient was in the on the day of evaluation, she was in the surveillance ward po, Doc. I was not allowed to come near po to the patient kasi there was merong partition po, Doc.
Okay, so you have to present it na it was done by the Pedia resident.
Yes po. Next slide. For the mental status examination, this patient was seen lying on the hospital bed on moderate high backrest, weak looking. She was wearing hospital gown and had good eye contact with the interviewer. However, there was difficulty hearing the patient's voice as the interviewer was not allowed to go inside the room. Communication was forced to the sister when the patient's voice was too weak to be heard. For the appearance and behavior, she was calm and was conversant. For the mood, she was sad because of her condition that she couldn't eat her favorite food and she had appropriate affect. For the speech, she had deliberate speech. She denied perceptual disturbances. The thought process was linear. She denied having delusions, preoccupations, and suicidal ideation.
Question.
Yes po.
How did she perceive the barang na she was, diba, she believed na na barang siya?
Actually, the barang was from the sister po, not from the patient po.
Pero sa presentation, di ba, parang is it only the family who believe na nabarang siya or what is the thought content of the patient? How did you explore?
During the time of evaluation po, Doc, this was not really wala pong nasabi ang patient about the barang. But it was galing po sa family and the patient had inconsistent po yung reasons niya for not eating. Sometimes she said na she would not eat kasi na it was due to yung nabarang. That's why she had loss of appetite and she had vomiting because of the barang. Sometimes she would say na hindi masarap yung food, lain ang taste. She had inconsistent answers po as to why she would not eat.
So the thought content is she is ambivalent whether she was barang or not. But
Okay.
there is a thought and as believed by the family na nabarang siya.
Yes po. Yes po.
Good morning po, Doc. This is Des po, Doc. So regarding the barang po, Doc, I was able to extract this from the patient po, Doc, na she thought that gibarang siya, Doc. Gidautan yung term niya, Doc, kasi after siya kumain ng turon, yun na nag-start na she choked on it and then she had discomfort in the abdomen and then she had diarrhea afterwards. So she thought na gidaot through the turod po, Dok. And then if this was supported by the mother po, Dok, na nabarang talaga po siya because the mother is also superstitious po, Dok.
So you cannot say that in your mental status exam that she denied having delusions, because there is the thought content is that she believes that she was barang by, and this was affirmed by the family. Am I right?
But yung parang reason po niya kasi, Dok, is yun nga po, Dok, inconsistent siya, Dok. Minsan mag-change din yung reason niya po.
Mm-mm. Kaya nga, she has ambivalence, and this is affirmed by the family na nabarang siya. Tama ba?
It was affirmed by the family po, Dok. Pero sa patient kasi, Dok, is hindi siya like fixed. So that's why we thought na hindi siya delusion.
Mhm. But it is very important to consider, no, sa thought content niya. So you can actually say na this is not denied kasi she is having other culture bound na mga beliefs. But you cannot totally, because this is the first interaction with the patient.
Yes. Yes po.
So you cannot conclude that, no, kasi this is the first interaction with the patient. Very important kasi ito to lead you to the diagnosis. Okay, thank you.
Thank you po.
Hello, good morning. Morning. Hello.
Yes. Yes po.
Oo. In relation with Dr. Benignos, with regards to the culture, is it the culture it should be culturally accepted, no? In their place, naniniwala ba sila ng that there is really a barang?
Only the mother po and the patient had this
The
belief.
mother and the patient, ang community nila.
During my po, Dok, sa course sa ward when I handled the patient, even the sister din po, Dok, the family actually believe po, Dok, na posibilidad nga na barang ang patient po, Dok.
So it's even, it's accepted in their community
Yes, po, Dok.
culturally.
It was a
that
cultural.
there is an existing barang.
Yes, po, Dok. It's yes.
So
In
they
their
always
family
relate, they always relate an illness or any medical problem that the barang could be one of the etiologic factors or the cause of their medical problems. Do you
Yes,
believe in
but
that?
they believe in that po, Dok. However, like Dr. Bello mentioned po, Dok, it's stronger with the mother and the patient po, Dok.
Okay. So if you have patients who are ambivalent or inconsistent with their yung mga sagot nila, how are you going to push it through? Paano mong gagawin just to make it makuha mo yung yung tama talaga na I mean, even though ambivalent sila, inconsistent nga, although the reliability, you need also to check on it, no? Is it really reliable? Was the patient telling the truth? Is how many percent? Parang ganon. You need also to check on that with to confirm it also with the family members. Of course, the mother is your informant. Tama ba ako?
Actually, the mother, for this case po, Dok, the mother really refused the interviews po, Dok. We can discuss po, Dok, how we try to explore later in the course of the wards po, Dok, since this is still the initial pa naman po, Dok. We will discuss po later in the course of the wards how we attempted to
Okay.
delineate po, Dok.
Sige.
Thank you po, Dok.
Sige. Thank you. Thank you.
Thank you po, Dok.
Pero taga saan nga ito? Taga saan sila? What is the community?
Sa Indangan lang po, Dok.
Indangan.
Yes po.
So here in Davao.
Yes po, Dok.
Kasi in relation to Dr. Mabunga's comment, no? So is it prevalent in Indangan? Meron silang mga belief about
Yeah.
the barang thing? Kasi you have to look into the community to consider it as culture-bound na presentation.
I haven't looked into that po, Dok. If the whole community po, Dok, believe that. But within the family, even the cousins, Dok, they pointed to that possible cause po, Dok. Barang.
So strong belief this is shared between the mom and the daughter, as you've said, am I right?
Yes po, Dok. Very strong.
Between the two of them.
Yes, po,
Okay, sige.
Hello. So to proceed for the neurovegetation, the patient had, during the initial, she had a good sleep, and she denied problems in sleep during the first evaluation. And then for the appetite, she had decreased appetite with decreased in weight. She was more active during daytime, and she had decreased libido, which could be attributed to her medical condition. And she was oriented to 3 spheres. And then for the tests for concentration and attention, these were not done as we not able to stay longer in the sa COVID surveillance facility. And then she had impaired judgment with no insight to her illness.
Sorry, yung let's go back to your attention, orientation, and concentration and attention not done. But what is your overall observation, no? Based on your interaction with the patient?
She had good attention po, Doc. As I can see her naman from afar na she was listening to me. She had good attention, but yun nga, malayo yung patient. So medyo difficult to hear ang voice during the first evaluation po.
Why did you say that the patient has impaired judgment?
Because of her, she would not feed, and she refused to be fed, Doc. And kahit na she was instructed to kahit in smaller amounts, she take in smaller amounts, she refused to
What was her reason then?
And she had inconsistent answers po, Doc, like pangit yung lasa, tapos baka magsuka siya, even if recently with sips of milk wala namang vomiting, but she refused to take food talaga, Doc.
How about the insight?
Regarding her illness po, she had no insight po, Doc. So she had inconsistent answers pa din, like for example, baka nabarang, kaya meron siyang medical illness.
So the insight was she believed na may sakit siya na nabarang siya. Tama ba
Yes,
ako?
Yes po, Doc.
Okay.
So to proceed po with the differential diagnosis. So we considered eating disorders. First is anorexia nervosa because of the restriction of food intake leading to her very significant weight loss. However, this was ruled out because there was no intense fear of gaining weight and becoming fat, and there was no disturbance in her body weight or shape or on self-evaluation. And ever since this patient was never, she was thin po talaga ever since, and she never had undergone yung mga diet or mga ano. So this was ruled out. So another consideration under the eating disorder was restrictive avoidant food intake disorder because it is an eating disturbance characterized by the fear of vomiting after eating and of the fear of gastrointestinal disturbance after feeding. So she refused to eat. And this resulted to significant weight loss with significant nutritional deficiency, with dependence on enteral feeding, and with marked interference with psychosocial functioning, as she had this led to her hospitalization, and this cannot be explained by lack of available food or because of cultural restrictions. And this eating disturbance is not attributable to anorexia, and it can't be attributable to another medical condition, as her present medical condition is secondary to the restrictions in her is secondary to her poor feeding. So as of the time of evaluation, I can't rule out the restrictive avoidant food intake disorder. However, I also considered na it can, her being choosy to food po, Doc, can, pwedeng ma-attribute to her being choosy. That's why she restricts herself from eating other types of food. This can be due to her OCPD traits also. And this can be attributable also to yung her traits of being rigid. She sticks on her known food, on her known brand, like that. So, however, this cannot be ruled out during the first encounter with the patient.
Question lang. No? Kasi as you've mentioned a while ago, she believed, no, in her insight na barang siya. That's why she has this medical condition. No? So can that be a symptom that would rule out
Sorry po, the barang kasi, Doc, for during parang consistent po talagang yung during the first encounter, like consistent
Sheng? Sheng? Your internet is not stable. Please switch muna so we can hear you clearly. Putol. Thank you.
Sorry, Doc, we have problems with the connection. Can we have your question again po, Doc? Hello?
Clear na ngayon, Mel?
Unstable. Madungog ako. Ay,
Yes.
sorry, Doc. Can we have the question again po, Doc? Sorry, Doc.
Hindi, kasi ito na-rule in mo yung restrictive avoidant, no? But there is part of the insight that you mentioned na she believed na barang siya that caused her, no, this medical illness. Which is not prominent in restrictive avoidant food intake disorder.
Yes po, Doc, but it was inconsistent po kasi during the first few days of the encounter with this patient. And she also had these reasons na she will not eat because of the fear of vomiting, because of the fear of having abdominal distress.
Okay. Let's listen to the other differentials.
Okay, delusional disorder po was also considered, in this patient because of the possible delusions, the possible belief that she was being cursed by the classmate, the parent, the mother of the classmate. But um, this can be ruled out as uh, it can be considered a culture bound belief, as the mother po, the family had this they believe they had these superstitious beliefs po. So this can be culture bound, and also uh, these delusions by the patient, this was not inconsistent po and was not fixed, as CP will give inconsistent answers as to why she will not eat. So during this time, the first few 3 days of the encounter with the patient, this was ruled out po. And then mood disorders were also considered. First is MDD because of the presence of depressive symptoms, the presence of the loss of appetite, the lack of energy, and the sad mood, which was due to her condition that she could not eat because she cannot tolerate feeding po. However, she was unable to, during the time of evaluation, she was unable to fulfill the 5 out of 9 symptoms of MDD. And also, her lack of energy, her being weak, can be attributable to her present medical condition, her severe malnutrition, her electrolyte imbalance, and the anemia. So this can be the reason why she lacked energy. So during the first encounter, this was ruled out. And another differential was bipolar disorder because she presented with a symptom of hypomania, which is increase in goal-directed activity, wherein she would stay up late at night to study. So she would sleep at 1 a.m. to 2 a.m. to do her homework po. And however, she was unable to fulfill criteria for hypomania. Other symptoms of mania or hypomania were not present, only the increase in goal-directed activity. And also this increase in her activity is also her premorbid personality, na she really stays up late to do her homework po, kasi she was a perfectionist. So she really laging inuulit-ulit yung assignments. So she would stay up late. So during the first encounter, this was ruled out. And then for the personality disorder, OCPD was considered because she displayed pattern of orderliness and perfectionism. So she was able to fulfill 4 criteria. So there was perfectionism that interfered with her task completion. For example, when given tasks, she would repeatedly redo just to be perfect, and she spent late hours at night to make it perfect. Hence, at times she would submit late, and that's one of the reason she was uh, bullied in school, that she was not hindi dapat siya maging valedictorian. And then there was also preoccupations with details and rules. She doesn't want her siblings to touch and rearrange her things on her study table. And then she was also excessively devoted to work, stays at night to do her homework and school-related tasks. And she displayed rigidity and stubbornness. She buys and eats specific foods in specific stores, and she will not eat food if it is not her preferred brand. For example, she would for example, hot dog, she would only eat tender juicy of the regular size. Pag jumbo size, she will not eat the hot dog po. And for example, if she eats siomai, she would buy in specific stores. And pag not on the specific restaurant or store, she will not eat the siomai. So the OCPD was ruled in po. And other medical conditions were also considered, such as yung upper gastrointestinal pathology or obstruction, because of the complaints of choking sensation that resulted to vomiting. And this can be ruled out because during the first week of the hospitalization, she was referred to ANP, and endoscopy was done, which revealed normal results. So this was ruled out. So during the first week of the evaluation, our impression was OCPD, and to consider restrictive avoidant food intake disorder. So to proceed po with the course in the ward, so this patient was referred on 28, and then she was
May I
first
question ako?
seen on March 29th. Ay, sorry po.
I have a question.
Yes po.
You diagnose your patient with OCPD.
Yes po. That was the consideration po during the first encounter po, Doc.
Ano ba yung age criteria ng OCPD?
It can be good morning po, Doc. Doc Neva po ito, Doc. It can be diagnosed po, Doc, at more than 18 years old po, Doc. However, personality disorder categories po, Doc, may, according sa DSM-5 po, Doc, may be applied with children or adolescents. In relatively unusual instances in which the individual's particular maladaptive personality traits may appear to be persistent and unlikely to be limited to a particular developmental stage or another mental disorder. So it should be recognized that the traits of a personality disorder may appear in childhood and will often be unchanged in adult life. Po,
Yung
Doc.
OCPD
So,
as official diagnosis in children? Meron bang personality disorder? I mean, it can present as early as adolescent. Ilang taon na yung patient?
18 years old po, Doc. Sa ano po
18 na
kasi,
pala ito?
yes po, Doc.
Okay.
Sa,
I thought 12 years old pa yung patient.
yes po, Doc.
So the patient is 18.
Yes po, Doc. Sa ano kasi, Doc, sa nabasa namin, Doc, sa DSM-5.
Okay.
Yes po, Doc.
Actually, you're giving a conclusion.
Sandali.
Sorry. Okay, go.
18
Please
years
don't-
old yung patient. Tapos sa Pedia siya. Nalito ako.
Yes po, Doc. 18 sa SPMC po, Doc. 19 po yung adult po, Doc.
19 and above. So 18 years old. So Pedia pa siya.
Yes po, Doc.
Okay. I thought. Sige. Okay,
Yes,
go
ma'am.
ahead.
I think at this point, no, you were more concentrated on the OCPD rather than OC traits lang, obsessive compulsive traits ng patient, which is specifically focused on food intake. Tama ba ako?
Yes po, Doc. And not on the food lang po, Doc, kasi she also displayed yung rigidity, like for example, she doesn't want her siblings to rearrange her things. It makes her uncomfortable po.
Didn't you consider Asperger's here? Kasi
During the sorry, I was not able to consider po
as
Asperger's.
part of your differential diagnosis.
No, I was not able to consider that po.
Especially, usually, hindi yan napapansin kasi matalino, no honor, no? Pero may mga preoccupation sila with perfectionism, diba? May specific, food to eat, no? These are the rigidities that you can see with Asperger's, which is very subtle.
Yes po.
Or a social pragmatic problem that can present as OCPD trait. So what is your main problem here? Kasi sa chronic malnutrition, this is more of the pediatric problem. So in terms of your psychiatric problem, So because this is a psychiatric emergency that you need to be aggressive kasi the patient came in with a very severe, a low BMI classified as severe. Diba? So,
So during the first few days of the evaluation po, of the sa main service, the problem was a chronic malnutrition and then the anemia, electrolyte imbalances.
on what day was the
uh,
patient referred? On what day of admission? This is very important.
On the second hospital day po.
Okay, you have to put it there in your presentation. Second day pa lang siya na more than a month na refusal to eat. So this is psychiatric emergency.
Yes po.
Yes
po. So psychiatric wise po, the problem seen in the patient was the refusal to eat. And also we had based on the history, parang she had poor family support, as I noticed that the watcher of the patient was her elder sister, and the mother refused to go to be the watcher of the patient. During that time, on the first week, the current management of the main service was for correction of the anemia, correction of the electrolyte imbalances po. And during that time, she was also referred to ENT, which in which flexible endoscopy was done, revealing normal result po. And during that time, she also had episode of fever, so she was started on AMPI plus sulbactam po. And for the management po, during the first few days, this patient was for further exploration. Once she will be transferred to the non-COVID ward. And then also one of the goal is to build rapport with the patient and the family, so as to get a thorough psychiatric history. So I also instructed to contact the family members to do a corroborative interview, but the mother refused to come. So this patient is for stabilization and correction of the medical problems. So during that time, supportive psychotherapy was rendered to the patient, and the main service was informed of the plans to optimize the patient and still to explore the family dynamics of the patient that may have caused the patient's current problem. And also it was suggested to insert NGT if there's no improvement in the appetite of the patient. And also the RIC was instructed to convince the family that the preferred watcher is the patient's mother, since during the interview we found out that this patient had this tendency to please the mother po, na mas susunod siya sa mother compared to the sister. And the sister also claimed na she was not close to this patient.
So since this is a psychiatric emergency, no, let them the pediatric staff should be working on the physical health of the patient. So the first thing that you have to consider here should have been the psychosocial trigger, and who is the amenable watcher, considering that the patient is not diba, in good relationship with the sister. Tama ba?
Yes po. Wala akong marinig. Wala akong marinig.
Hello po, Doc. Sorry, Doc.
To
cut off po,
to
Doc.
hello? Sorry.
Hello po, Doc.
Oo.
Doc, sorry, Doc. The relationship between the two elder sisters po, Doc, and the patient. However, she was close to the mother po, Doc.
Oo. Kaya nga. Tapos hindi pa ang mother niya ang watcher. Also, ano lang, why did you not consider shared psychosis here? Kasi, di ba, sabi mo, both the mother and the patient, the mother stronger, di ba, the relationship with the mother and and the patient is stronger and they share the same belief, how did you rule out shared psychosis? Kasi you were focusing on delusion eh. So it can be part of the psychosis. So was this something that you considered in your differentials?
Actually, yes po. This was also considered,
But this was not presented in your
Yes po.
differentials?
yes po, kasi I was parang considering culture bound since the mother po, very superstitious po talaga yung mother ever since po.
Kaya nga. So yung pathology, no, you have to
Yes
look
po.
into the pathology. So these are the things that should have been explored, no, in the first week
Yes po.
pa lang. Kasi yun na nga. Sige, let's listen.
Okay. So
Excuse me,
Yes
you said
po.
that the mother is supportive. Supportive in terms of what?
The mother is not supportive po though.
But she is also supporting in terms of how the patient believe.
The mother
Because
was sorry po.
Because
The
she
mother
agree,
yes
she
po.
agree and she believe. Okay. So I think you should also to consider this, no? It's part of your differential diagnosis. Kasi they might be also she might be also part of the same ano yung psychotic ano. So, yun nga, parang shared nga. That's what Dr. Benigno said. I was also thinking at the start about this because you need also to consider this is also very important.
Yes po, this should have been considered po in the first encounter. Thank you po.
Is your patient psychotic?
Yes po, Doc. Sorry po. Hindi marinig.
Is your patient psychotic?
During the time of evaluation, no other signs po of psychosis. No hallucination po, no disorganized behavior, and denied having delusions.
Pero yung ano niya, yung thought content niya, yung barang niya, ideas of reference, or yung mother, parang mayroong persecutory na aspect sa thinking niya. Don't you think na psychotic yung patient? I think that's the first thing
yes.
that you have to rule out.
Yes po. Yes po.
Oo, from the
Bakit siya
very
dinala
start.
doon sa psychiatric facility in the first place? Bakit yung eldest sister? Bakit yun yung isip niya? Ang history kasi is lacking, no? No, were there anything na bakit siya dinala ng eldest sister ba yun?
Yes po.
Bakit niya naisipan na doon sa private?
The eldest sister kasi she got worried sa medical condition as the patient appeared very weak na, and mas according sa kanila sa private na dala kasi yun yung mas malapit sa kanila po.
Was it a medical facility or psychiatric facility?
Medical facility po.
Medical pala.
Yes
Okay.
po. Yes po, Doc.
I thought psychiatric na.
So I suspect no na parang from the very beginning pa these are prodrome signs of psychosis. So it started within the family. Pero sige, let's listen pa to your course. So how did you work? Sorry, how did you work with in an ideal setting? How did you work with a nutritionist? And the pediatrician, since this is CL work,
Good morning po, Doc. This is Des po, Doc. So, on the second week po, Doc, so the main problems of the main service were the chronic malnutrition, and then the anemia po, and then the electrolyte imbalance, and then this time po the X-ray showed pulmonary infection po, Doc. Mayroon pong pulmonary congestion with left-sided minimal pleural effusion, and then cannot rule out pneumonia po, Doc. So yung psychiatric po na problem na determined this time po, Doc, is the refusal of the patient to eat po, and then poor family support. So for the findings po, Doc, the patient was lying in bed, weak looking. She was awake, but unconversant. She was irritable with appropriate affect. She had deliberate speech. She had interrupted sleep. Though around this time po, Doc, she had improving appetite po, Doc. Kasi previously, sips of the milk lang po yung iniinom niya. But this time around, she was able to drink half a glass of Ensure po, Doc. And then she was able to eat some solid food po of her choice, like French fries, biscuit, and then yung kamote Q po, Doc. However, she refused to eat rice and viand as it would, according to her, it would make her vomit po, Doc, kay lain daw yung feeling ng rice at saka viand. She denied perceptual disturbances. There were no suicidal ideations. She had no preoccupation. She's oriented. She had unimpaired memory. She exhibited abstract thought. She had good fund of knowledge. She had impaired judgment. I attributed this po, Doc, to her refusal to eat certain food po, Doc, and then no insight to her illness. So for the actions during this time po, Doc, though nag-improve po yung appetite niya, but still I judge it to be hindi enough. So I suggest NGP insertion po, Doc, to facilitate feeding and correction of the electrolyte imbalance, which is nagawa naman po, Doc. And then strengthen po yung therapeutic alliance. And then the supportive psychotherapy was rendered. And then kasi nga na determine na po, Doc, na yung mother, yung kasi parang nakuha namin, Doc, sa history is closest yung patient to the mother, and then parang nag-follow talaga siya kay mother. So requested po na the mother to take an active role in patient care. However, the mother refused po, Doc, because at that time po, takot siyang magka-COVID. So, yun po yung nangyari. And then, for further exploration po, Doc, yung mga psychosocial factors.
how did you work with the, how many times in a span of weeks, how many times did you see the patient and the mother and the family?
Ano po, Doc, everyday po kasi binivisit po yung yung patient, and then during this time po, change po sila ng watcher, kasi yung previous is yung second sister, the elder sister. This time around po, Doc, niece po yung nagabantay sa kanya po, Doc. So yun po, sila po yung nakakausap po, Doc, the patient and the niece po, Doc. So some information regarding the history I got from the niece po, Doc. And then regarding yung nag-request ng mother, yun po, pinipressure ko po si niece na sabihan yung yung mother na magpunta. However, yun nga, ayaw daw talaga. Tapos si niece, medyo din siya, may hesitation in her part kasi may, daw, parang like yung sabi daw, the term was maldita daw si mother. Kaya Kaya yun hindi nakapunta yung mother po, Doc. Hindi siya nakatake ng active role sa patient care po, Doc.
So at this time, no, your diagnosis is still OCPD, and to consider ARFID, na considering you've been seeing the patient for 2 weeks already. So what is the, by this time you could have gotten siguro a more clear picture on the diagnosis and the of the patient, and could have worked with a family with clear goals.
Yung ano ko po, Doc, actually I was leaning to RFID po during this time, kaya consider ko po siya because yung in-explore ko po yung reason niya po talaga kung bakit ayaw siya mag-eat. Yung kanya po is yung sensation ng food na parang receive na effect po, Dok, ba na makavomit siya na kapag mag-eat siya makavomit siya, kaya ayaw niyang mag-eat. So yun po yung kaya during this time leaning po ako sa RFID po, Dok.
How about the belief that she was choked, no? Related to the barang, di ba? Yun yung nasabi ni Sheng.
Yes po, Dok. I
Did you
explored.
explore?
Yes po, Doc. I explored po on that po, Doc. Pero inconsistent kasi siya, Doc. Yes, she mentioned it, Doc, na after eating the turon, na-choke siya and then doon na na-start. And then I asked her ano yung view niya regarding it. So sabi niya na yun nga, nabarang siya. And then I tried challenging it po, Doc. Kasi madami man silang kumain ng turon, pero siya lang yung na parang na-choke. Pero yun nga po, wala siyang, ano kasi, Dok, parang wala siyang insight. Tapos parang naisip niya that time is, it could be parang gidaot siya kay, yun nga, kasi yung nagbigay ng turon is the mother nung top 2 na student. So parang feeling niya parang gi-sabotage siya para hindi siya magiging top 1. Parang ganun po, Dok, yung thinking niya at that time po, Dok.
So it's consistent. So maybe did you not think that this is a possible sign of psychosis talaga? Kasi 2 weeks na and nasabi mo na yun pa rin, ma-relate niya pa rin pala, nagidaot siya. So, at this point, 2 weeks na siya. Hindi pa rin tayo, hindi pa rin natin yung establish yung right diagnosis. Still to consider.
At this time po talaga, Dok, personally hindi ko po talaga consider yung yung psychosis na part po, Dok. Na more on yung sa feeding na ano po ako, leaning po ako doon sa
na-focus ka sa ARFID.
Yes po, Dok, sa feeding and the personality po ng patient na yung rigid po siya, Dok.
Okay, in retrospect,
Hello. Sorry.
what could have been done? Or in retrospect, no, considering this discussion, no, what are the possible learning points here? Ay, sorry, sa last part na pala yan. Sorry, nasa pa pala tayo, no? Of course.
Yes, po, Dok.
Go, Pao.
Yeah, kasi the condition started parang 3 months prior. 3 months prior, no? Pero before, like ano yung eating pattern ng patient? So you have an adult patient, pero like before that, ano yung eating history niya?
Yung eating history niya po, Doc, is very picky eater po talaga siya. like specific brands of hot dog. So dapat tender juicy lang. And then specific size. And then like example sa siomai, this specific store lang kayo dapat. And then meron din siyang tendency po, Dok, na hindi nagkakain ng mga bigay na mga pagkain. Like example, magbigay daw yung neighbor nila na relative kasi may party. Hindi siya nagkakain kasi
Bakit?
baka dirty. Baka dirty yung
Ginahiluan siya?
pagkain. Hindi po, Dok. Dirty po, Dok, yung ano. Kasi parang yung food preparation, Dok, ba? So baka hindi malinis. So hindi siya nagkakain. And then sa mga ano din po, Dok, isa din po yun sa parang nag-wonder ako kasi yung sa mga vendors po, Dok, hindi siya masyadong kasi nga very very particular siya doon. Pero tinanggap niya yung turon na offered to her. Pero yun na din, tas doon na din na trigger siya na baka gidaot siya. Kasi very ano siya very specific na parang hindi siya nagkakain sa yung mga galing sa mga vendors or mga bigay because of issues ng cleanliness po, Dok.
How about weight issues?
Wala po, Doc. During the first few weeks po, Doc, we really explore this on her regarding weight issues. Wala po siyang problema sa weight issues. In fact, she's sad po, Doc, kasi naniwang na siya. And then also she's sad also na hindi siya makakain ng kanyang favorite food kasi nasusuka daw niya. Yun po yung nakuha namin sa kanya po, Doc.
So yung mga body image issues, wala siya doon?
Wala po, Doc. Wala po siyang sa weight, yung sa shape. Wala po akong nakuha sa kanya, Doc. I particularly asked her about it. Wala po siyang issues doon. Ang ano lang niya talaga, ang ulit-ulit niyang sinasabi is lain ang feeling. Yung term niya is lain, kaya nasusukan niya. Pero I asked her, masakit ba? Hindi naman daw, lain lang daw. Kaya nasusukan niya yung food. And she's becoming frustrated about it po, Doc.
So walang body image issues?
Wala po.
Walang drive to be thin?
Wala po.
She doesn't feel feel niya na mataba siya. That's why ayaw niyang kumain.
Wala po.
Wala yun siya. Did you ask kung like how would she describe herself physically?
Ang nakuha ko po sa kanya, Doc, is nasad siya, Doc, kasi niwang na siya masyado.
Pero yung reason na hindi siya kumakain, like have you asked kung ano yung underlying reason?
Yun nga, yung sabi niya po, Doc, is lain ang feeling sa food. Lain daw sa iyang baba. So I asked her, masakit ba kung kainin or anong ibig niyang sabihin sa lain? Hindi po niya na-expound. Yung sabi lang niya is lain talaga. Kaya
Pero did you ask kung pinahiluan ba siya na?
Yes po, Doc. Wala naman po, Doc. Hindi siya nag-isip
ano yung motivation ng barang?
Ano po, Doc? Wala. Yung regarding sa poison, I asked her about it. Wala po siyang ganun na issue. Kasi in fact, along the course po, Doc, pa-assignment po to siya ng anong gusto niyang pagkain na which she believes na hindi siya magsuka para yun yung bilhin ng kanyang watcher. And then, nakain naman niya po, Doc, yung mga choices niya po na ibang food. Tapos minsan din, nag-request siya ng pagkain para dalhin ng family from the outside. Eventually, nakain niya, Doc, pero minimal lang. Pero nakain niya, Doc. So walang ganong issue po, Doc, na baka na-poison siya po, Doc.
Des,
Yes po, Doc.
ano kasi, like if you look at the pattern, no, sabi mo 3 months and even when was younger pa, no, you can see the pattern there that there is parang contamination problems or obsessions. Kasi 'di ba, hindi siya magkain, pipili niya, no. So these are signs, pwede bang fixated siya into this and it becomes delusional na belief?
Yeah, pathological doubt.
'Di ba? Matagal na gud yan and oo. And then this one precipitated by the eating ng banana. And if you look at yung mga yung mga precipitating factors, very lang mababaw lang yon that could have triggered premorbid na na symptom. Maybe siguro
In
this
retrospect po,
should have
Doc,
been
is that-
something that you have checked. No?
Yes po, Doc. In retrospect po, Doc, we should
In
have
retrospect,
thought about it po, Doc. Yes po.
kasi nito, naka-second week na, wala pa tayo nakabigay ng antipsychotic, no? So please proceed na daw kung or may questions pa ba? Yung iba.
On week 3 po, so same pa din po yung ng main service about the electrolyte imbalance and then the pulmonary infection. And then around this time po, Doc, yun na po, na-note ko na po na depressed yung patient, mostly because sa kanyang state na yun nga, niwang na siya masyado, hindi niya nakakain yung favorite food niya, tapos kung magkain siya, nasusukan niya. So nag-consider po ako ng comorbid na mood po, Doc, MDD. So patient was lying or sitting on bed, tapos irritable or sad mood with appropriate affect, she had spontaneous speech, she had good sleep, improving appetite. So this time around, full glasses of Ensure na yung naiinom niya po, Doc. Parang breakfast, lunch, dinner niya. And then, nag-drink din siya ng soup. Itong soup po, Doc, is as requested niya po. So nakadrink siya ng soup. And then, nakakain siya ng mga yung bread, biscuit, and then yung chips po, Doc.
Were you the one managing that instead of the nutritionist? Were you the one focusing on those?
Ano po, Doc, yung ano po dito po kasi yung para ma-promote po na magkain yung patient, yung preference niya po, yung parang encourage ko po sa kanya yung preferred na food niya. Yung sa Pedia po, and then the nutritionist, itong Ensure po, Doc. Meron po silang timing nito, Doc, kung how many times, and then the volume also sa Ensure na mag-intake yung patient.
At this third week of your interaction with the patient and the family, so what have you, yung psychosocial, kasi if this is a eating disorder, this is a family disease. So what is like the, I think I am more concerned on how you have been dealing with the psychosocial aspect, because this is part of the aspect, yung malnutrition niya, yung food intake niya is part of the problem of the Pedia. So if I were to ask you now, so what is the specific goal here on the third week, working with the family, dealing with the psychosocial aspect, working with the family to be supportive towards the patient? And it is the watcher, because from the very beginning, the patient was requesting her mother to be the watcher. At this point, how did you engage that they should be working together to help the patient? And maybe,
Yes po, Doc. During this time po, Doc, it's still the niece who was the watcher. And then, yung nasa week 3 pa. Week 3. 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa week 3 pa. Week 3. At tapos yung ano po, Doc, yung nasa yung para ma-involve po yung si mother po do kasi nga ayaw niyang ayaw niyang magpunta. Yung nakita po na solution po Doc is yung video chat. So yung nangyari po Doc is naga-video chat siya with the mother, and then sometimes sabayan siyang magkain ng kapag magkain si mother, yun din time na parang painumin siya ng ng yung gatas niya. So kaya medyo nag-improve din yung kanyang appetite. And personally po, Doc, yung nakita ko po is isa rin sa nag-improve yung kanyang eating po, Doc, is because of the knees. Kasi yung sa dynamics kasi nila, Doc, the elder sister, yung isang watcher is isa din siya sa nagabully ng patient. So medyo meron ding sa kanilang relationship. However, with this niece is siya parang outsider. So walang hindi strained yung kanilang relationship. So and then so sa pagkain, sa pag-support sa pagkain, mas nako-convince ni niece si patient na magkain. So isa din po 'yun sa factor na nakita ko na naka-help na nag-improve yung eating ng patient. And then
Please proceed.
so for the week 4 po, Doc, so yun nga na meron na siyang napansin ko na po yung depressed mood. However, with her with her activity this time around, nagatayo na po siya, Doc. Kasi before naka-diaper man ito siya, pero this time wala na po siyang diaper. Mag-walk po siya towards the CR para mag-CR. And then may mga times na maabutan ko siya na naga-play with her cellphone. However, ano pa din siya with yung sa depressed mood niya po with appropriate affect, and then spontaneous speech, and then this time nagareklamo siya na interrupted sleep because of the ward activities. Tapos improving yung appetite, yun nga yung full glasses of ensure, soup, biscuit, bread. Tapos this time around nakakain na po siya ng rice. Kasi prior, rice talaga yung pinakaayaw niya, rice at lugaw kasi nasusuka daw talaga niya. Pero this time, nakakain siya ng rice pero 2 spoons lang. So, and then din siya, na-trick din siya into eating meat kasi tinago ng niece yung meat sa ilalim ng rice. So ito ko siya nito, gi-encourage ko siya nito na parang continue na wag dili lang like a super fast kay it's parang tawag nito achievement na nakakain na siya ng rice na hindi siya nagsuka. And then denied perceptual disturbances, so no preoccupations, oriented to 3 spheres. So same pa din po yung the rest of the MSE. So this time, because of yung mood na ko po, Doc, na detect ko po, Doc, I plan to start antidepressant, pero considering po yung electrolyte imbalances. So plan pa lang siya po, and then to start if makorek po yung sodium electrolytes, especially the sodium levels. Nakikita ko naman po na increasing yung sodium levels, but below pa din siya sa normal. So, nawala ang kuwan. Nawala. So, ito po yung, kasi yung sa Pedia na na din sila, kasi palang na na sila na bang pwede bang mabigay na gamot. So, I talked to the RIC and explained to her yung itong plan ng antidepressant, and then the reason for the hesitation of starting kasi nga with the electrolyte imbalance. So na understand naman po ng Pedia, so nag si Pedia na talaga yung nila yung correction. And then supportive psychotherapy. And then this time around, nag-initiate na po ako ng insight building. Kasi nga, then nakakain na siya ng konting rice, tapos increasing na yung number of food na makakain niya na hindi siya nagasuka. So naggawa kami ng activity. So pinagawa ko siya ng assignment. So parang list of ano yung food na gusto niya, ano yung food na ayaw niya, tapos ano yung food na makapavomit sa kanya, tapos ano yung food na hindi siya makavomit. So yun po yung assignment sa kanya. So nag-cooperate naman po yung patient, agree naman po siya na gawin niya ito. And then with the improvement po ng appetite, kasi nga kumakain na, nagplano po yung Pedia na itos na siya sa atin. So yun po yung yun po yung nag-refer po ako sa iyo po, Doctor, referred to Dr. Benignos regarding the TOS. And then, yun nga, there was no indication for admission at IPDM kasi that time, i-optimize talaga yung medical management. And then this time, naano na po ako na RFeed yung patient. And then personally personally po, Doc, na ano din ako kasi hindi ako makabigay ng antidepressant. And then, since improving na yung patient, I was thinking na what are mga ibang like sa atin po, mga mabigay natin para mas mag-improve pa yung patient. So, I read up on our feed, and then doon sa nabasa ko po is some individuals were given risperidone na nag-respond po yung patient na nag-increase yung appetite with risperidone. So I suggested it po. However, at that time po, the response was for biopsychosocial exploration, more biopsychosocial exploration, and then at that time, no indication to start risperidone. So hindi po ako nag-start ng risperidone at that time.
Question. This
Yes po,
patient
Doc.
was referred to me on the 4th week na.
Yes po, Doc. Sa
So,
4th week ko na po
from the very beginning, hindi ito na-refer. At the 4th week na pala na-refer sa akin.
Hello po, Doc. This is Sheng po. This was referred to Dr. Daganao po when I first encountered this patient. However, I haven't received a reply from her. So I should have followed up po sa mga succeeding days po, Doc.
O kasi the referrals that you gave lang na, I was just wondering, that's why kasi you did not consider catatonia even in your differential diagnosis eh. So kasi I was asking but anyway, this could have been supervised, no? Dapat on a more aggressive manner in terms of psychosocial intervention. So I think marami sana tayong nagawa for this patient. So sige, sige, please proceed.
So on week 5 po, Doc, during sa late na po na kasi na okay pa siya yung April 26 to para April 29. Pero on the 29th po, Doc, yun na po, Doc, na nagkaroon po siya ng hypotensive episode and then also episode of difficulty of breathing. So that time, seen lying in bed, weak looking, deliberate na yung speech niya po. Tapos she refused further interview and she would prefer to sleep. And then there was loss of appetite. So back to minimal intake of milk, minimal intake of biscuits and fruits. So this time, nagkain siya ng apple at saka orange. And then, so I suggested NGT reinsertion. But the main service was worried about yung vasovagal reaction that might exacerbate yung hypotension. And then this time also po, nag-change ulit ng watcher. So hindi na si Miss, si ano na, balik to elder sister. So actually personally at this time also po Doc, parang at one point na consider ko na baka na weak, parang medyo nawala na naman yung appetite ng patient because of the change in the watcher kasi hindi man niya ito kasundo si elder sister. So isa ito sa in-explore ko sa kanya. But however, according to the patient, happy man daw siya na si sister yung yung watcher niya. And then at this time, nakita ko rin na worried si sister. So I also gave supportive psychotherapy to the sister. And then I followed up on the mother na magpunta na siya to take an active role on the patient care, but still she refused po, Doc, because of health reasons. This time yung sabi niya is matanda na daw siya, and then kasi daw bago lang daw siya na operahan, and then pero yung operation niya po is hemorrhoidectomy. Pero yun po yung reason niya po, and then she would prefer na naga-video chat with the patient. In fairness naman po, Doc, I observe na everyday naman po sila nag-video chat with the patient.
Good morning po, Doc. Clear? So, I received the patient po, Doc, on the week 6 na po, Doc. At this time po, Doc, the main service diagnosis was electrolyte imbalance, secondary to chronic malnutrition, anemia, probably nutritional, and dilated cardiomyopathy. This patient po at that time had hypotensive episodes and difficulty of breathing. She was seen lying in bed. She was already weak looking with deliberate speech and would refuse intake of food, and also would refuse the interview and prefer to sleep as she feels weak. She would attempt to reach out to the third interviewer and sister to hold hands and would sleep most of the time. So at the time po, Doc, the patient had blue stools as well and febrile episodes with hypotensive episodes. So she was already on four different kinds of suppressors. And at the time, the main service was planning to was considering this is due to the pneumonia. And so they shifted clindamycin to vancomycin. Psychosocial findings po, Doc, at that time. So I find out that sa ako na interview na po, Doc, that the mother was manipulative and controlling, and that she refused initially the admission of the patient. And until up to that week po, Doc, was blaming the sisters for bringing the patient to the hospital. And she was blaming the sisters for the patient's current state. So she also refused to go to the hospital, and although I attempted to call her, she refused interview. I was considering already that the mother had a psychopathology because according to the eldest sister at the time, she would accuse her daughters of being mistresses of her husband. And the father is submissive and cannot say against the mother. When I called the father also po, Doc, the father is a senior citizen and had pneumonia on X-ray. So he was not allowed to go to the hospital to give support to the patient. So I also noted for caregiver fatigue with the elder sisters, they already had edema due to prolonged standing. And also, Doc, they refused NGT insertion because the mother strongly forbade it. So, given the medical condition of the patient, the optimization of the medical management was advised. So, I conferred with the RIC that we really need to facilitate feeding through NGT, and she said that there was a strong refusal from the family. So, I advised that if they will not refuse, they can have the family sign the waiver. But what I did po, Doc, since I was considering basically incapacitated ang mother to decide, I called the social worker in the main service to probably intervene, and they interviewed the eldest sister, and they also had the same findings with me na the mother is might be is a problem po, Doc. So the SPMC social worker coordinated also with the barangay social worker to do a house visit. So meanwhile, the social services allowed the elder sister to give consent to the NGT. So at that week, on the same day po, Doc, na that I referred, the NGT was already inserted. I referred at the back of my mind po, Doc, I referred to you po, Doc, because I was thinking na medyo bordering on the delusion na po na side ng why she would not take the food. So I also researched on our field and saw case reports wherein risperidone can be beneficial to the patient. However, given the medical condition of the patient at that time, when I referred to Doc, I was advised to defer muna starting on psychotropic medications because it will exacerbate the hypotensive episodes and we might cause harm to the patient because of the uncorrected electrolyte imbalances, especially since the patient still had ongoing fluid losses. And I was also advised to explore more on the mood of the patient since we are also considering a concurrent comorbid major depressive disorder for this patient. On the next, still on the week 6 po, Doc, on the next days, this patient still had the same problem. She still had loose stools and she still had ongoing hypotensive episodes. So at the time, the patient was already on NGP and was receiving appropriate caloric intake, but she was still weak and would refuse the interview and preferred to sleep po, Doc. She still had loose stools at that time and uncorrected electrolytes. So still the psychotropic medications were deferred until the patient is more stable. So at this point, I strengthened my alliance with the sisters and supportive psychotherapy was rendered to them. Still coordinated with the social worker and I was pushing for the social worker to for us to conduct a family meeting so that the mother might come in for interview. However, on the week 7 naman po, Doc, specifically on May 10, we still had a deteriorating medical condition. And at on May 10 po, Doc, there was noted visual hallucinations verbalized by the patient, and she already had fluctuating sensorium and disorientation. However, despite this, there was no episodes of agitation that impeded the medical management of the patient. So when I had my rounds, they already gave risperidone now, one tablet. However, given the medical conditions of the patient, I advised to hold muna the risperidone for the following reasons at that time. The patient's psychotic symptoms is better attributed to delirium, which is more hyperactive in presentation due to the multiple etiologies, such as hypoxia with the persistent hypotension, anemia, and related cardiomyopathy of the patient, electrolyte imbalances, and infection. So giving antipsychotics may precipitate exacerbation of hypotensive episodes and may increase risk of arrhythmia, especially since the patient had dilated cardiomyopathy with ejection fraction of only 26% and with increased QTC interval. The patient is also not agitated at that time, nor was there any aggressive behavior, nor did the symptoms impose safety concerns or impede in the advancement of medical care. And also, I was considering that since it is hypoactive, it is more associated with dopamine scarcity rather than excess. And treatment with antipsychotics may exacerbate severity of delirium and prolong psychomotor retardation, or even promote catatonic pictures. So I advised optimization of the medical management to address the primary medical condition of the patient. I referred also this at the status of the patient to Dr. Benitez at that time, and I was advised to ask permission from cardio if they are amenable to start antipsychotics since they are also on board. Um, Also for the psychosocial management, I was able to schedule a meeting with the family, with the social worker. However, they were not able to bring in the mother, and although they have already given consent for the NGP, they were still hesitant. The next problem was the consent for the cut down, because again, the mother would refuse. So supportive psychotherapy was rendered again to the eldest sister, noted to have caregiver fatigue and frustration also towards the mother, who continued to refuse taking care of the patient. So, however, on the next day, I was supposed to ask permission from the cardio with regards use of antipsychotic to control the delirium. However, at the next day, the condition of the patient further deteriorated. She was already GCS 8, A2, B2, and 4. She was transferred to PICU. And they were considering septic shock secondary to healthcare associated pneumonia at the time with hypoxia, dilated cardiomyopathy, and chronic malnutrition. So at the time, the delirium was, there was no active psychosis. And since there was no delirious process, we deferred giving antipsychotic and psychotics and advised to optimize medical management. Supportive psychotherapy was rendered to sisters. However, they were not allowed as watchers in the ICU. So that was the status of the patient from May 11 to 15. And still at the time, I did attempts to contact the mother through the social worker because she was not responding to my calls for doc. And on May 16, the patient had cardiopulmonary arrest, and even despite resuscitative efforts done by the main service, the patient expired. Their sign-out diagnosis at the time was septic shock secondary to healthcare associated pneumonia with hypoxia, dilated cardiomyopathy, chronic malnutrition, stunted, severely wasted, secondary to avoidant restrictive food disorder, and non-COVID. I tried to contact the RIC photo of this patient right after I learned about the ano po, doc. However, she was otherwise indisposed po, doc. She had since this is a confidential man po, doc, she had the RIC actually had a relapse of her symptoms na bipolar 2 and consulted here at IPPN because of suicidal ideations. And unfortunately po, doc, we wanted to have a more comprehensive presentation. However, we cannot access really the chart because it was already in the medical records, and we need 3 days to access it. But this is what we saw as much as we can. So this was their sign out for the diagnosis. This patient succumbed to infection secondary to HACO.
Okay, that's the last of your presentation, Well.
Yes, but that's the last slide.
Okay, kasi what we need to answer now is what could have been done so that we can prevent that also for our next patients.
Siguro, to be more specific, no? So, ang question lang is this preventable yung, I mean, what are the errors of omissions identified here?
We can start chronologically siguro. So, Sheng, during your time of management, what could have been done?
Hello po. During the first 3 days that I saw this patient, I should have explored more on the patient's delusions. And I should have followed up Dr. Laganao kasi on the when I first saw this patient, I messaged her po, Doc, but on the second and third hospital day of referral, I was not able to follow up po.
At this time, Sheng, were you able to identify that it is a psychiatric emergency?
Yes, yes po. Yes po.
So all the more that we have to be aggressive, no? With regards
Yes po.
to referring these patients. Kasi complicated eh.
Yes po.
What else?
What
Sheng?
else?
In my this is Des po, Doc. In my part po, Doc, since this is a difficult case, I should have referred more with our consultant po, Doc. Like very frequent po, especially yung sa ano po, Doc, sa progress po ng patient and what I was able to get during the exploration po, Doc, sa mga psychosocial issues niya, Doc, for a more in-depth po na supervision and then also sa guidance din po sa management po ng patient po, Doc.
Okay, Des, no, but yun nga, no, for everyone, it's not really, we're not fault finding here. What I'm trying to ask here is also parang management-wise for this particular patient. Ano ba yung na-miss natin? At which part of the management could we have intervened more? Siguro yun yung ano ko.
Siguro, Doc, may I speak po, no?
Go ahead.
I was siguro, Doc, more on the identification sa diagnosis nato, Doc. If kasi nga this patient had more or less more delusional po, Doc. It was always a kanang central question na parang delusional siya, and regardless if delusion and our treatment ko, Doc, management with psychotropics is ano po, Doc, according sa journals is beneficial. However,
we have consider that, ba?
Doc, we had yes po, Doc, we consider that po, Doc, pero at the time po, Doc, na when I handled the patient, she was already kanang deteriorating na medically po, Doc, and at the time po, Doc, starting psychotropics would be unethical po, Doc, ng primum nocere, Doc, ba?
Delayed ng referral. Sorry ha, but I think we are not here to put you down, no, but we have to take this constructively. So we are identifying the errors of omission, commission. So questions if this is preventable. So I just like to talk first, no? Kasi first and foremost, I think this was referred late. The patient was referred on the 4th week na. And then I think there is a problem here with the diagnosis. And then since this is a psychiatric emergency, the main psychosocial issue was not addressed, no? That has kept, no, actually that has contributed to the continuing food refusal, which can also be a sign of yung that could have heightened the psychotic symptoms. So I think these are the things that you have to learn from this case. And there should be an aggressive psychosocial intervention for this kind of patients.
Also, since CL siya, no, yung coordination with Pedia, kasi di ba there were some management that they also could not say yes to, di ba? Yes?
Yung sorry.
Yes, Doc.
Yung referral kasi na like to start antipsychotic was really delayed, no, on the 6th week na severe na yung niya, physical complication, medical complication. So if the antipsychotic could have started earlier, and there's a strong working alliance with the patient and the relatives to really have clear objectives on the behavioral intervention to to encourage the patient to eat, we could have, I think at this point we could have done better, kasi yung complication na lang kasi ng ng psych itong nangyayari sa pasyente. We're not able to engage the patient to eat well, and I think with an ideal setting, yung fear nyo to really work to start antipsychotic is there. So I have actually advised Nueva na you have to really work parang closely with the cardio, kasi di ba they refuse the antipsychotic. But in an ideal setting, you can have telemetry to monitor the cardiac status of the patient, from the very beginning. So working closely with the cardio, with telemetry, monitoring, hindi tayo matatakot to give an antipsychotic eh. So even we start at a low dose, kasi it seems like from the very beginning, meron tayong fixated na preoccupations with eating, and then precipitated by this choking, and the underlying psychosocial problem, within the family was not addressed immediately. So it was not consistent, in the presentation. Some residents would say that the patient would want the mother to be the watcher, but on the last part, there was an ongoing problem with the parent-daughter, with the mother-daughter relationship. Am I right to hear that? So this was not addressed properly. So this would have been something to have worked on earlier.
Hello. Ay, permission to talk.
Thank you.
Oo. Actually, based on the sa ating presentation, so we said that it could have been prevented, the death. So we were thinking is more of a psychiatric disorder that lead into a medical problem, and that's the cause of the death, ang kanyang medical problem. That's probably yung the sepsis. So although there are actually in our practice, there are sometimes gray area, na hindi tayo too sure, especially wala nga proper evaluations pa yung ibang workup that we need to have it with this patient. Like, hindi naman siya makapsychological test kasi it was already referred sa atin na medyo hindi na kaya yung mga ganyan na workup. It could have been siguro to start nga, kasi hindi florid, hindi mo kaagad makikita, But for me, personally, I would just start at a very low dose with all the workups lang, like if it has a cardiotoxic effect, nephrotoxic effect, and everything. So yun nga siguro lang, just get all the baseline, and there's no fear siguro of giving at a very, very low dose. Probably nga, mas earlier lang ang identifications para mapaaga din yung management natin, especially with the psychiatric problem. So if could have been earlier ang referral, and it could have been ang interventions natin, medyo hindi tayo hesitant with all the backup natin, with all the workup nga na we have in mind the possible side effects. So I think we don't hesitate, and there's no fear of giving it at a low dose, just to lang yung ating mga doubts and the gray area ba. That's my personal opinion. Thank you.
Yes po, Doc. Personally po, Doc, it was a lapse of my judgment po, Doc, to not refer at the very early po, Doc, sa state po ng patient na yung ano pa po siya, Doc, yung well pa po siya, Doc.
Okay, what else, Nuev, can we identify na pwede nating mag-change? Socially, kasi di ba there was also a concern socially. Was it difficult for the social services to address?
They were actually, Doc, when I called the social services, they were very accommodating naman po, Doc. And they were fast naman po, Doc, na on the same hour that I called them, they already interviewed the sister. However, it was more on the refusal po, Doc, ng mother when they, I asked them to contact na lang po, Doc, then the barangay kasi na social worker so that they can do the house visit and check on the mother so that kasi dalawa po yung naging concern doon, Doc, yung sa NGP and cut down later on sa NGP with some pressure sa social worker, nag-consent naman po, Doc, and the eldest sister was able to give the consent and the mother was po, Doc, I only saw the mother po, Doc, on the day na wala na yung patient and that was the only time na na po, Doc, na kanang nag-meet na ang the whole family, Doc, ba?
Ano ang plan
The social
at this time? Or parang how was it disclosed? The death, and then what's their plan now?
When I arrived po, Doc, they were already waiting for the na po, Doc, kanang post-mortem na care. I offered na lang po, Doc, support to the eldest sister because they were really expecting that the patient would get better since she was already placed in the ICU. And the mother cannot po, Doc, does not want to refuse talaga po, Doc, to talk about it po, Doc. So I did not press po at that time, especially na pa po yung death.
Okay, are they planning to explore the cause of death?
Wala naman po, Doc. The eldest sister talked to me twice after the death po, Doc. She was, naman po, Doc, she was thankful naman po, Doc, of the services that they extended to her family. Her po, Doc, was more on frustration with regards to their mother and concerned about their 8-year-old na sister po, Doc. Since they were thinking that the mother would her influence again to the 8 years old and it would happen again. So I na lang po, Doc, nito sa social worker to really work closely na marati case study ang family, Doc, ba?
Okay, with this, di ba, they will have their, di ba, conference for this mortality, including the psych.
That's still, ba't po, Doc, kasi yung RIC nila, Doc, is in
Na-stress.
dili lang, Doc, ng ka-suicidal ideation kay na siya since this is just a confidential po, Doc, ka ng bipolar, man siya, Doc, bipolar 2. And when she did not take the test very well po, Doc, she had suicidal ideations and was advised admission. I don't think na makaya nila i-conference since the primary RIC would disposed.
Be prepared.
Question lang. Ay, sorry,
Yeah.
go.
Yes, Doc. Just be prepared, Nuev, to,
Yes, but
to
no.
explain to Pedia, and we can have, the help of our consultant naman for this case, ha? Kasi it
Yes,
really
po,
is
Doc.
complicated, multifactorial, and we na-identify, that's why Dr. Benignos mentioned that it would be good to have this mortality conference as soon as possible so we can also assist you when you do present this case sa Pedia.
Yes, Doc. We appreciate po, Doc, all the insights and inputs po, in this conference po.
O, last lang. convinced ka that this is ARFID? Purely ARFID?
ARFID, pero ano Doc, as I texted you before Doc, I was really ano po Doc, na considering na more psychotic po na quality yung sa food intake po niya Doc. That's why I was considering on starting risperidone.
So how will you present this if you will be called in the conference? So yung avoidant restrictive food intake disorder, 3 months prodrome kasi siya eh. So
when you look into the ano po Doc sa DSM-5-PR, it should really comply din naman po Doc with the ARFID na diagnosis. But maybe we can place po Doc na we can rule out psychotic na ano po Doc, like delusional disorder.
I think it's more on the OC traits, no? Kasi at the very beginning, sabi niyo OCD.
Yes,
But the restriction, the rigidity is based only on one aspect, which is the food from the very beginning, diba? So you have to consider, I think the diagnosis, the comorbid here was not fully explored.
Yes, but
maybe you can okay lang na anytime you can text me or let's have a parang discussion for this patient if you're going to present it with the Pedia department to help you and to guide them also na yung strong working alliance with us kasi very important
yes po Doc.
Okay.
Thank you very much po Doc. Especially in guiding us in this stage po Doc.